everyone. My name is Elena Kidd, and I'm a program director at the University of Alabama at Birmingham School of Public Health, Office of Public Health Practice. I'm excited to welcome you to today's webinar, Beyond the Basics, Cleaning and Disinfection to Mitigate the Spread of Infectious Diseases, including MDROs for Healthcare Facilities, featuring A.C. Burke, Vice President of Healthcare Quality with RB Health Partners Incorporated. This is the third webinar that is part of our webinar series focused on multi-drug resistant organisms, or MDROs. This webinar is made possible by the Alabama Regional Center for Infection Prevention, Control, Training, and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past webinars and podcasts, sign up for our newsletter, request training or technical assistance, and view infection prevention and control resources at our website, uab.edu/ARC-IPC. And you can also email arcipc@uab.edu, and those are both on our slide. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Center. You can learn more about their programs and the centers as a whole on the websites listed on this screen. We'd also like to let you know about our next upcoming webinar, also with A.C. Burke, Legionella Prevention and Water Management, or Water System Management in Nursing Homes. This webinar is around Legionella and other waterborne pathogens, as they have been associated with outbreaks in nursing home settings, causing infections in residents that may lead to severe illness or death. This session will discuss factors that contribute to the contaminated water sources and how this can lead to resident infections. CMS now requires nursing homes to have water management plans, and this session will discuss the CDC's guidance for developing an effective water management program to not only meet this requirement, but to also help ensure the safety of nursing home residents. This webinar is presented by the ARC-IPC and co-sponsored by the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Centers. It will be held April 23rd at 12 p.m. Central Standard Time. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, and complete the evaluation following the program. Upon completion of the evaluation, you'll be redirected to the Alabama Nursing CEU request form, which you will also need to complete. For nurses in the state of Alabama who are watching this program live, CEUs will be awarded by the Deep South Center for Occupational Health and Safety automatically. You do not have to submit directly to the Alabama Board of Nursing. For those seeking a certificate of participation, please also complete the Alabama Nursing CEU request form, and there's going to be a place for you to select that you would like to request a certificate of participation. CE units for this program will expire on April 11th, 2025. If you experience any issues, please email arcipc@uab.edu and we'll place this email in the chat box as well. And finally, it is my pleasure to introduce our speaker. A.C. Burke has been working with RB Health Partners Incorporated since 2016 and has over 22 years of experience working in public health and healthcare. A.C. worked with the Florida Department of Health for 15 years. 5 of those years, she served as the Healthcare Associated Infection Prevention Manager. She was later the Director of Infection Prevention for the Mayo Clinic, Florida. In her current role, she consults with long-term care facilities on infection prevention and control policies, procedures, and practices, and provides training to nursing homes at conferences, including the 17-hour Nursing Home Infection Prevention Program, or NIP, Nipping Infections in the Bud. NIP was created to meet the CMS infection prevention training required for a facility team member to be recognized as the designated infection prevention control official. We now would like to welcome A.C. Burke. So thank you so much for being here, and I will pass things over to you.
Thank you, Elena. It is certainly a pleasure to be with you all again and to be talking about cleaning and disinfection. Actually, cleaning and disinfection is one of a topic that I actually have a lot of passion about. And it was kind of fun to go back and be and prepare for this webinar and go back and refresh my memory on a few things. So there we go. All right. So in terms of what we'll be talking about today, so we're going to briefly touch on the core components of an environmental cleaning and disinfection program. We're going to talk about some of the different methods and tools used to apply disinfectants, talking about the advantages and limitations of disinfection practices, and also I'm going to just touch on some supplemental cleaning and disinfection practices as well. So a lot to cover, short period of time, but hopefully you all find some good nuggets of information to assist you with your programs. All right, so just a few reminders. So certainly we know that the role of the environment plays a huge role in the transmission of infections. So just like with how we view our overall infection prevention and control programs, we have to bundle our practices. So even within environmental cleaning and disinfection, we also have a bundle, if you will, for environmental cleaning. So it's bundles on top of bundles on top of bundles, so to speak. A lot of studies, there's a lot of literature out there, a lot of evidence-based practice or information for evidence-based practice as it relates to cleaning and disinfection. Our focus today is going to be on cleaning of the environment and non-critical surfaces, so non-critical type of equipment and surfaces. So we know that that the environment in terms of, or there's some factors, if you will, about the environment and the pathogens that influence how likely it is that that pathogen can ultimately cause infections and be a part of infection transmission. So there have been studies that have been done that have even looked at, let's say, inoculating the floor with a non-infectious type virus, and looking to see how long it takes for that to spread throughout a patient room. I will say most of these studies have been done in the hospital setting as opposed to long-term care, but certainly the expectation is that the principles would certainly still apply within long-term care. But nonetheless, in looking at floors, basically they could trace how that pathogens get spread from patients' shoes to patients' hands, and then ultimately to high-touch surfaces within the room. So we know that for sure, without question, the environment plays a huge role in the transmission of pathogens and leading to infections. So just kind of a reminder in terms of our pathogens. So there's some of our pathogens are easier to kill than others in the environment. So the enveloped viruses being the easiest to kill. So I try to kind of think of enveloped easy as a reminder. And then spores such as C. difficile being the hardest to kill in the environment. So certainly we have a lot of different bacteria and viruses that we expect to encounter on a daily basis. And this is just kind of the spectrum in terms of from the easy to the most difficult to kill. So we have the bacteria, then we have the non-envelope viruses, and then the mycobacteria. So big question. So if I'm an MDRO, am I harder to kill in the environment? So, and the short answer is no. So in terms of our MDROs, so when we talk about MDROs versus, let's say, Staph aureus versus MRSA. So in terms of killing that pathogen in the environment, it's the same whether it's a resistant pathogen or not. So in terms of our conversation, the information that's presented, it's applicable to both MDROs and also those pathogens when they're not necessarily an MDRO. So they're harder to treat, but not necessarily harder to kill in the environment. And as always, our goal ultimately is we want to be breaking the chain of infection, and certainly in the environment as part of that chain. All right, so our core components. So we definitely need to make sure that we have policies and procedures based on evidence-based practice. We want to try to have standardized protocols. So protocols for the frontline care staff, our nursing staff, as well as our housekeeping staff. So we need to make sure that we have both sets of protocols. Within our policies and procedures, we also want to make sure that we address who's responsible for what. So housekeeping needs to know what they're responsible for, and nursing, respiratory therapy, physical therapy, everyone needs to know what they're responsible for cleaning. So For example, sometimes I encounter there might be debate on who cleans the pump, who cleans the pole that the pump is on. So again, we want to make sure that we've kind of walked through this. We walked through the equipment that we have in our rooms and making sure that we know who's doing what. We also want to make sure that it's clear in terms of what the expectations are for personal protective equipment and what equipment needs to be worn when using certain products, and also making sure that it's understood, especially for housekeeping, that they understand if there's PPE that they need to wear in, say, the transmission-based precautions rooms. We also have some information from CDC as it relates to the airborne contamination removal time. So I don't know if any of you might have come across this table, maybe during COVID. We spent a lot more time talking about this. But nonetheless, I just wanted to kind of refresh your memories that this resource is out there. So when we think about pathogens that may be in the air, so how much time, for example, do we need to leave a room closed off, say before someone goes in there without their N95 on, for example. So what do those time frames look like? So this table, so that first column, ACH, that stands for air changes per hour. So that's the air change within the room, how long it takes to exchange with outside air coming into the room. And then these are minutes. So 138 minutes, 207, those are minutes. So how many minutes does it take to for the air to potentially clear out so that anything that may be floating around in the air would hopefully no longer be infectious to someone going in without the appropriate PPE on. So that's what this table tells us. I will mention here, though, the time frames on this table are based on like a perfect mixing factor. And that's like in terms of the combination of outside air, inside air. And I suspect that most of us don't have perfect mixing factors, but nonetheless, it gives you a way to potentially kind of estimate what those time frames would be. And I've included the link here on the slide. Cleaning from top to bottom. So we want to clean from the higher surfaces to the lower surfaces. The idea being that dust, debris that's on the higher surfaces, they're going to fall to the lower surfaces. Now, with that being said, so actually, I have some fresh examples. I was in several facilities last week. In one of the facilities, they were very happy that their housekeeper that they usually have clean a room when surveyors want to see. And the first thing she starts with is one of those like feather type dusters. And they were using that, and the resident was in the room, and they're dusting above the resident's head and all the high surfaces. So we do need to remember that it's not recommended that we're dusting anything above a patient's head when they are in the room, because again, we don't want it falling on them. And then also the feather type dusters aren't recommended because we don't want to disturb and spread the dust to other areas of the room. So kind of more of that damp dusting is what we want to be thinking about. The cleaner to dirtiest surfaces. So when we think about some of the literature that's out there, so there are some studies that have kind of identified what is the likelihood of contamination of those surfaces. And some of the studies have documented between 30 to 60% of the surfaces that are in that patient zone that are closer to the patient are likely to be contaminated. Most of these studies were done with some of the pathogens that are harder to kill, as well as MDROs. So again, like where do we get this from? So basically based on what's the likelihood of those surfaces to be contaminated. And then we also want to do the bathroom and the floors last, so the dirtier surfaces. Another thing that I saw in my observations last week is one of the housekeepers. So she was cleaning in the bathroom, and then the cloth that she had used on the toilet, then she turned around and used on like the bathroom door. So so just kind of some things to remind ourselves, what are we looking for? So certainly when we're going from those cleaner to dirtier surfaces, after we clean those dirtier surfaces, then we need to discard or not discard, but put the cloth that we're using in the bag, the dirty bag for being laundered. If we are using the disposable wipes, then yes, then discarding those wipes and then getting a new one. Selection of disinfection products. So honestly, I'll tell you, when I was thinking about this presentation, I'm like, oh my gosh, what direction do we want to go in? And I did think about giving a lot of information on disinfection products, but then I was thinking you might feel like you're back in chemistry class, and I can promise you, I don't want to go back to chemistry class. So Just kind of an awareness of, there's certainly some different pros and cons to the different types of chemicals that are used in the disinfection products. A lot of the ones that we're using, especially for the environment and the non-critical surfaces, we have a lot more similarities in terms of what we're choosing. So there are definitely things to kind of be thinking about when we're making those choices for selecting a product. So there are some things like in terms of how does a product smell, that can certainly influence how the staff feels about using it, and their likelihood of using it appropriately. We definitely want to make sure that the product is non-toxic. So we don't want it to be irritating to the user. We also, other things that we want to be thinking about, like flammability. Most of the products, they also have like a flammability rating. Surface compatibility. So I'm sure many of you that have experience with bleach, you know that bleach can be much more harsh on surfaces. And sometimes we might have to replace equipment more often if we're using a lot of bleach. So again, surface compatibility. And then persistence. So what is the persistence of the product in terms of sustained antimicrobial activity? Of course, education by job role, as with everything else that we are working on in our facilities, and then evaluation of practices. And we're going to spend some time talking about the evaluation of practices. All right, so disinfection products. So just a reminder, we have the EPA and the FDA. So for the non-critical surfaces, so for the environmental surfaces and non-critical surfaces, which is what we are referring to today, the EPA is the one that is the regulator for those products. The FDA, they regulate the products that are used, or the disinfectants for the medical devices and sterilants for the critical and semi-critical devices. All right, so this list, so this is the list where we can go and look up the different products. I will tell you that there has been an update to this list. So we used to have list E. Yeah, we used to have list E, and that has been removed and has been replaced with list S. And I can tell you, I am very happy with this change because of what list E had on it was very confusing with list B. And I'm glad that it's all been clarified with list S. So now that we've run through the alphabet, we will carry on. But nonetheless, you have the link there. So if you want to look up an EPA number, if you want to validate some of the information on a label, if you don't have enough information on one of your product labels, then you can use the EPA number on those products to look up more information about them. All right, so we do indeed want to make sure that the product that we're using is indeed effective against the pathogens found in the healthcare environment. So I am happy to say that since COVID, I've seen a lot less of the household type disinfectants in the healthcare facilities. During the earlier phases of the pandemic, when I went into facilities, I did see a lot of the household type disinfectants as opposed to the healthcare grade disinfectants. And I'm thankful that it seems like we've gotten back to the healthcare grade disinfectants. And of course, we want to make sure that we are sticking with that. So we want to make sure that what we have is a broad spectrum. So in terms of really making sure that the products we've chosen do indeed cover the pathogens that we are likely to find in a healthcare environment. Of course, we need to make sure that we are following the manufacturer's instructions. We certainly know how important that is when it comes to the contact time and making sure that we're adhering to that. Not topping off bottles. Many times when I'm doing rounds and I talk with housekeepers, I do hear a lot of times that they are indeed topping off bottles. So this may be something you want to look into within your organization. But nonetheless, it is important to make sure that, again, we're not topping off bottles and refilling, if you will, according to manufacturer's instructions. And I know we talked about sprays at the boot camp, but I just can't help to give that reminder that indeed sprays are not recommended. There were some questions that came in about the sprays after the boot camp. So in terms of CDC guidance, we do have language in the environmental infection control guidelines from CDC that speaks to avoiding large surface cleaning methods that produce mists or aerosols or disperse dust in patient care areas. So we do have some language from that guideline. All right, so contact times. I know we've talked about contact times. The shorter the contact time, the better in terms of the likelihood of having adherence. I do have the comment here, if the surface dries too quickly, then reapply the product. But ideally, we want a product that that's not going to happen with, because we know the likelihood of actually getting that product reapplied is probably very low. So again, we want to make sure that our staff understand those contact times and that we are indeed adhering to them. All right, so one of the challenges that we have, if we're going to do a little deeper dive into contact times, and so when I was trying to look for pictures, when I came across this picture, that picture is how I feel sometimes when I really have to do a little bit of a deeper dive into what's going on with the housekeeping chemicals and what they're using for cleaning. A lot of times when you go and read these labels, some of the products that are used by housekeeping and also truthfully for nursing too, just my experience has been it gets a lot more complicated with some of those housekeeping products, is that the manufacturer may list different contact times for different pathogens. And so then sometimes you get challenged with, okay, what am I teaching to? I can't teach all these different contact times. So then of course we're going to pick the longest contact time for teaching purposes for consistency. But then the other issue that comes up sometimes is that contact times may vary by concentration. So there's different levels of concentration. You can buy some of the products at different levels of concentration. If you're mixing on site, you can mix to different levels of concentration. And then product labels, not only are they different time periods for the pathogens, then there's also different time periods for the level of concentration. And I can tell you that sometimes when you're trying to find out the level of concentration that's being used, that can be incredibly challenging. But nonetheless, sometimes we do need to do that deep dive to make sure that, again, that we are circling back to and we are adhering to those manufacturer's instructions to help ensure that we are indeed killing the pathogens in the environment. So just kind of keep that in mind when you're reviewing products and also reviewing practices. That's something that we do want to make sure that we are looking at. Okay. All right, so within the healthcare environment, so hospitals and nursing homes, so we have seen more of the transition to the microfiber mops. So many facilities are indeed using the microfiber cleaning cloths, and many are also using the microfiber mops, the mop pads. So there is a lot of literature out there as it relates to the different fabrics and how the different fabrics interact with the different chemicals. So in terms of okay, why do we care, so to speak? So generally speaking, microfiber has been demonstrated to be superior to cotton. So cotton mop heads, cotton cleaning cloths for cleaning and disinfection. Now, that being said, some of the microfiber cloths and mop pads aren't as effective with certain products. So for example, they're not typically they're not compatible with our bleach-based products. So sometimes there are limitations, but nonetheless, generally speaking, the microfiber is preferred at this point in time. There have actually been studies that have demonstrated that sometimes the cotton mop heads, we can actually spread pathogens, contributing to greater spread of the pathogens in the environment as opposed to actually cleaning, and which is our goal when we're mopping, right, as opposed to actually cleaning and disinfecting the floors. So if you still have cotton mop heads, definitely we have to look very closely at those practices. Certainly our preference would be to transition to the microfiber. And even with the cotton mop heads, technically we can adhere to everything that's listed in the CDC guidelines because they say no double dipping. So when we're using the microfiber cleaning cloths, ideally we're soaking them in the disinfectant, then we're using them to clean the surface. There are actually some instructions within CDC that talk about how you fold the cloth, and you use one side of the cloth for each surface, and then you change the other side with the folding. Ultimately, you get to 8 sides kind of a thing. But with the microfiber, so we want to make sure that we are cleaning using one side of the cloth and then discarding, so we're never double dipping. So the microfiber cloth, it never goes back into that clean solution. But like, for example, when we're using the cotton mop heads, we are double dipping. So the microfiber certainly being a better choice. There's also some supplemental, or what is often referred to in the literature as the no-touch disinfection. So we have the UV radiation, or the UV lights, and the hydrogen peroxide vapor, or some just say HP for short. But in terms of the no-touch systems, we still need to clean the room. So it's not like you just, after a patient leaves, we just go and pop in the UV light and we're done. We know we still have to clean the room first, and then we'd use the no-touch system, or supplemental system, if you will. So there's still that manual cleaning process that has to occur. There is evidence that no-touch methods can reduce environmental cleaning contamination with healthcare-associated pathogens. However, before I continue talking, I will flip to the CDC slide, where, and I just checked these guidelines again online, and CDC still states that the 2003-2008 recommendations still apply. However, CDC does not yet make a recommendation regarding these newer technologies. This issue will be revisited as additional evidence becomes available. So I've given you the link there. So that being said, in terms of CDC, I will still share with you that there's still a lot of evidence out there as it relates to using these no-touch systems. So I don't know how many of you have done deep dives into the literature as it relates to cleaning and disinfection, but there are 3 authors that have contributed a lot to this body of evidence. And I have the reference here for one of them. So William Rutala, David Weber with the University of North Carolina, and then there's also Philip Carling. Actually, Philip Carling's work is referenced on the CDC website when you look at their toolkits that they have for implementing an evaluation program for cleaning and disinfection of resident and patient care rooms. So these 3 people have contributed a lot. So in terms of the language, that there is indeed evidence. So when we look at a summary of the review of the studies that have been done, so Rutala and Weber state that yes, there is indeed evidence that no-touch methods can reduce environmental contamination within the environment. Okay. So in terms of these studies, so some of the pathogens that have been studied as it relates to UV and the hydrogen peroxide. So MRSA and C. diff typically on the list, and then for the UV lights, VRE and Acinetobacter have been included, and for the hydrogen peroxide, Mycobacterium tuberculosis and Serratia. So those of you who might remember some of the discussion of the different pathogens from the boot camp, so Acinetobacter being very, very difficult to kill in the environment. And actually it was Philip Carling who had the study where he demonstrated that basically a patient room that was occupied by someone with Acinetobacter, that the risk to infection to the next person going into that room was like over 300% in terms of their increased risk of acquiring that pathogen. So Acinetobacter being one of those pathogens, it's very, very hardy in the environment. So one of those that's more difficult to kill. And then also, when we talk about the levels of disinfectants, so we have low level, intermediate level, high level, and the sterilants in terms of the different levels of disinfectants. So tuberculosis, Mycobacterium tuberculosis, kind of being that pathogen that's used to identify that intermediate level disinfectant. So again, a pathogen that is much harder to kill in the environment. And then of course we know C. diff and the spores is challenging to kill. So those being pathogens that we like to see in these types of studies. And then MRSA is also being used. So one of the things with MRSA is because it is more common in the environment, it's easier to be one of those pathogens that is used in terms of those pre-post studies, because we do see it more often in the environment. All right. So in terms of the no-touch system, certainly we have advantages and disadvantages to both. We'll need more time for that terminal room cleaning, because again, we still have to do the manual cleaning, and then the time for, let's say, the UV light. There's some logistics with moving and setting up of the equipment, monitoring the equipment use. And then also with these technologies, so we have with the UV light, one of the challenges that has come up in terms of one of the common challenges, is that the light, there may be some shadows in the room. So the surfaces that might fall into the shadows of where the light is being radiated to, then those surfaces aren't going to benefit from that disinfection. So many times facilities have found that they need to do multiple cycles with the UV lights to kind of make sure they've addressed some of those shadow areas. And then for the hydrogen peroxide, so this can also be influenced by the concentration that's used, the dissemination, and your air removal time. So how long it takes for that to sufficiently dissipate in the room before it's safe to enter. All right, so evaluation of practices. I'm going to pause for just a second. I see a couple things in the chat. I'm just going to just take a quick peek. All right, so it looks like Elena was sending out the slides. Excellent. Okay. And I don't see anything in the Q&A. Okay, so moving into our final section, if you will, of what we want to talk about today, and also maybe a little bit more of the meat of the matter, so to speak. So evaluation of practices. So we know that that we need to be evaluating our programs. We need to have a way to monitor effectiveness, monitoring adherence to our protocols. So I couldn't help but to take the opportunity to throw in a QA tool. So the Plan, Do, Study, Act, or PDSA, is probably a tool that would be very beneficial to us in terms of helping us with developing and implementing a monitoring program. So kind of in that planning phase, who, what, when, where. Then for the do, implementing that plan, a lot of time goes into that plan, implementing that plan, start collecting our data, providing the feedback. Then we're going to study what's happened. So what happened when we implemented? So summarizing, reviewing the data, assessing outcomes, and then typically for the act, adopt, adapt, or abandon. So, and I'll talk a little bit more about these, but I just kind of wanted to give us a framework that maybe we can start thinking about this as we think about developing and implementing or enhancing a monitoring program for cleaning and disinfection. So, all right, so the who, so be thinking about who will monitor. So in many of the studies that are in the literature, there's different people who may monitor. The studies have also included even housekeeping supervisors being included in that group of people for doing the monitoring. So we may have infection prevention staff, we may have housekeeping supervisors or managers, and there may be other groups that you want to include. So let's think about who will be doing the monitoring. So what are we checking exactly? So what method are we going to be doing to evaluate our processes? What surfaces are going to be included? And then what data is going to be collected? So what data are we going to collect? Who's it going to be reported to? How's it going to be reported? What does that look like? So the when, what are our timelines? So what are the frequency of the assessments for our different periods of time? So baseline measurement period, implementation period, study period. So what are those timelines? What does that look like? How often are we going to do the assessments? And then will our time frames for doing assessments, will it be scalable? So maybe in the beginning, we're doing some a lot more frequently, and then we may be able to do them less frequently once we've made improvements. And then what does that look like? So if we stop, so kind of our performance begins to decrease because in correlation with decreasing the frequency of our assessments, then do we need to increase our frequency again? So again, kind of looking at what would the frequency of assessments be? So initially versus ongoing, and then where are we going to focus our efforts? Where are we going to focus this evaluation? So the assessment. So what units or locations in the facilities? Are we going to include common areas? Are we just focused on the patient and resident rooms, or do we want to be looking at both? So some things to kind of be thinking about is in that planning phase for our program. All right, so just kind of generally speaking as we talk through this. So certainly the expectation is that we already have staff that are working in housekeeping and that they're already doing cleaning and disinfection. Our expectations, we already have frontline staff, care staff that are doing the cleaning of equipment and things like that. So expectation is we already have the cleaning disinfection program in place. All right. So when we're developing our monitoring program, our performance improvement program, however you want to refer to it. So having that baseline measurement period. So that would include going out and evaluating, let's say now, kind of see where we are. And then we're going to implement our improvement plan. Okay, so I almost want to say it's almost like the covert checking. So we're going out, we're evaluating cleaning of the surfaces now before they know that we're checking it more closely, see how we're doing. Then we have a great point for comparison in terms of improvement. So then we'll implement our program. So based on our findings of baseline measurement, that can help us target our education. During the implementation, we want to provide that real-time staff feedback, so that one-on-one coaching on an immediate time frame, as well as providing group level feedback. So higher level feedback that may be going to our IP committees or our QAPI committees, in terms of what does the summary data look like, how are we doing, and then having that post measurement period. So we've done all of these things to try to make those improvements, and now we're gonna go back and reassess and kind of see, okay, how are we doing? Did we make improvement from our baseline? And then of course we want to make sure that we don't forget thinking about sustainment. So what do we need to do to help sustain our practices? I suspect many of you have had experiences where we can make improvements, and then as soon as we take our eye off the ball, sometimes we slip a little bit in terms of our performance. So what is sustainment? All right, so the different methods. So what do we have for different methods? So cleanliness versus cleaning. So there's some technical differences, if you will, in terms of those definitions. So cleanliness, really looking at, do we have the infectious bioburden, if you will, left behind? So there's ATP testing that can help measure residual bioburden, but there's some pros and cons to that in culture. So before I get to the next one, I do want to jump ahead to my next slide. So those of you who might not be familiar with ATP testing, but it basically, it measures the organic matter on surfaces. So the challenge with this is that it can be either viable or non-viable organic matter. So it can be a little more challenging in terms of interpreting those results. For culture, so when we look at culture, we have to do the pre and post. So we need to culture before cleaning, culture after cleaning, to really be able to measure the impact. So there definitely can be some challenges for cleanliness measurement, but nonetheless, those are indeed methods that are out there. And that being said, there are challenges, there's pros and cons to all of these methods. So we don't have the perfect method out there, but nonetheless, we'll talk about these, and there are, each of these methods has something to offer, if you will, in terms of helping us to evaluate our programs. And then we have cleaning. So have we actually completed the cleaning process? So direct observation, certainly many of you can anticipate one of the challenges there. So when you're standing there watching someone, they know that they're being watched. They might not do the same thing as they do or follow the same process when they're not being watched. So that Hawthorne effect that we've heard about, so that's certainly being a challenge with the direct observation. Nonetheless, I still think there's a lot of benefit to direct observation because sometimes it can really help to see in terms of processes, if there's an opportunity for improvement in the process. So just like I shared with you earlier in the presentation. So last week I was doing some observations in the feather type dusting, the dusting above the resident's head. So there are some things that in the process, there still might be opportunities for improvement that we can find and see through that direct observation. Visual inspection, so that's when we're just kind of checking to see, does the surface look like it's been cleaned or not? Is it visibly soiled? So I can tell you oftentimes when I'm doing rounds in facilities, so a lot of times what I end up doing is visual inspection. Does this look visibly soiled? And then along those lines, I do want to share, so for those of you who are doing the rounds and doing the checks, I don't know what's going on, but I've been in a lot of buildings over the last few months, and it seems like every building I am finding a visibly soiled pump in the clean room wrapped in the plastic bag. So they're in their clean bags, they're in the clean room. But I don't know what the trend is, but it seems like I'm finding a lot of visibly soiled pumps out there. So those of you, just kind of give you something to think about. Maybe you need to go check and see what's going on in your facility. But nonetheless, so that visual inspection is, does it look visibly soiled? And then another cleaning process for evaluation is fluorescent markers. And that's what we're going to spend most of our time on. That's what we're going to talk about. So the fluorescent markers are the fluorescent gels, if you will. So I believe that Elena's team and the program that you all have there in Alabama, they've been able to provide the fluorescent gel. Actually, at the boot camp, you guys got the fluorescent gel kits and things. So the fluorescent markers, the fluorescent gels, there's a lot of literature that supports using this process for evaluating our cleaning processes. So it has been demonstrated in many of these studies in terms of, yes, the fluorescent markers really were technically only evaluating cleaning, but it has been demonstrated to be a good proxy measure, if you will, for evaluating the likelihood of cleanliness occurring on the surfaces that are being checked. So hopefully that makes sense to you all. And if not, we'll have a few minutes in Q&A, and then hopefully I'll be able to clarify then with that. Okay, talked about ATP. All right, so this is just an example of another study that was done, that was published based on the COVID-19 days. So environmental cleaning and disinfection are fundamental to our healthcare infection prevention. So this study evaluated the disinfection compliance of high-touch surfaces in a COVID-19 ICU using the fluorescent marker. So they did the three phases, so baseline, implementation, and then post-assessment. So, and they were able to demonstrate compliance improving significantly from the first to the third phase, from 14.3% to 51.4%, respectively. So I did come across this study. It was just published in April. I wanted to try to pull a more recent study, but I do want you all to appreciate that there are lots of studies that are out there. Some of them are a little bit older, but there are a lot of studies out there that have validated this process in terms of being beneficial for improving cleaning practices in facilities. Also along those lines, most of these studies show very low compliance. So this one has the 14.3% compliance. And it was certainly not unusual in many of these studies to have very low levels of compliance in that baseline assessment period. And then all of them having significant improvement for that post-assessment period. So again, this is just one of the more recent studies, but there are a bunch of studies out there that have looked at this process. All right, so this is an example of another study. This one was published in 2018. So this one did include the UV gel for marking the surfaces, but they actually really focused on the value of the feedback for the staff. So, so again, another study that validates the process, but then using that validation, this particular study looked at the importance of the audit and feedback as part of the process. So they did a 16-week program, included long-term care facilities and critical access, hospitals. So of course they included the training, the environmental services leaders. So EVS stands for environmental services. My apologies for not spelling that out. Environmental services leaders trained on the use of the UV gel for marking the surfaces, weekly audits, and then they reported that data. They provided feedback to staff. So they had some of that immediate one-on-one coaching. And then there's also that aggregate data and using that aggregate data to target their additional education. So let's say, for example, they picked their surfaces, door handles, room door handles were included in those surfaces. Then they could look at that data and be like, you know what, that seems to be the surface that we're missing most often. we're going to go back and re-educate and help our staff remember to to make sure that they're cleaning those door handles. So that's what we mean by using that data to help target the additional education. Also, in some of the other studies that were done, there's definitely support out there for using the I just lost my train of thought. Checklists, for using checklists. So some of the studies with the gel markers and their as part of their implementation for making improvements, they use checklists. So there was some definitely some support in the literature for using checklists as well. So kind of looking at the improvements made here. So another example, so the long-term care facilities, again, that very low initial compliance at 17%, and then they increased to 73%. Those raw numbers are the numbers of surfaces checked, and then compliance with that. And then for the critical access hospital, so they went from 64% and increased to 98% in terms of their cleaning, again, using the gel method. So again, another example out there of the validation of this process that it really can help with that performance improvement. All right, so let's say we're going to look at some how we're going to do this. Okay, so how would I implement this if it were me? So that we have our different time frames. So baseline, intervention, post. We're going to select the surfaces that we're going to mark. So I just used 5 here for example. So then these would be the surfaces that are going to go and be marked with the gel, and then we're going to use the light after the cleaning to see if those marks have actually been cleaned off of the surface. So the checking, so the audits. So we'd give feedback immediately to the housekeeper, and then again summarizing those numbers for compliance. So I know after the boot camp, we got some questions about, okay, so what does this data really look like? And what's the hands-on with this? So I tried to try to come up with something that looks kind of hands-on-ish. So now that being said, I mean, CDC, for example, they have lots of tools out there and spreadsheets and resources. So there's definitely other resources, but like I said, I tried to kind of think through this when I've gone and done this, and it's been a long time since I've gone out and done this. But when I'm out doing rounds and I'm out tracking something, honestly, I want a little piece of paper that I can write marks on for tracking my numbers. Would it be nice if I could have an iPad and plug it into something? Yes, it would. But the reality is that's not really what's happening. So I created like a little table that I might make for myself, and I'm going for me to go out and do those checks to see, okay, has the gel been wiped off? So I'm out with my little flashlight and I got my little paper where I can track. So here I just did room numbers, dates, and times. So my experience has been, and I'm sure this is different for everyone, just my experience has been, if I have the room number and the time of the check, I can correlate that back to a specific housekeeper. So to be able to also give that housekeeper specific information. Some of you may prefer a column that has housekeeper on it, you can, but for me, when I was going out and doing these, I didn't know which housekeeper did it at that time because I'm going in after they've cleaned to check those surfaces. So something to think about in terms of how you organize for yourself for tracking this. So going in and checking the surfaces, and then I'm just doing 1 or 0. So 1, the mark is off, 0, it isn't off. So just doing it that way. I have a thing for 10s because it's easier for me to count them and add them up over time. So I had my 10 lines, and then you can go and plug them in. So when you get back to your office, you can go and plug them into Excel files, and Excel can do all sorts of math for you to be helpful. So I just tried to keep this a little more simple. So the surfaces, put it in. And so here, again, we can look at compliance by surface. So again, we think about that targeted education. The bathroom light switch, we definitely got to call some attention to that, for example. Sink faucet, we're doing great. Overall compliance, we still have opportunities for improvement. But nonetheless, this kind of helps you see how you're doing. And then, as I mentioned, we certainly want to keep that staff-specific feedback, and then we also still want to have the higher-level summary of the information. So, again, just kind of think through what's the best way to do that. And then I just kind of created I dummied up some graphs. You know, what does this look like? So, within PowerPoint, even it helps in terms of creating graphs for learning how to do that. So And some of this may be preference. Do you like bars? Do you like lines? Do you like tables? I'll concede I'm a little bit more of a table girl in terms of being able to look down a list and see some numbers, but graphs, we also want to include some graphs. Again, all of our minds work a little bit differently in terms of how we process a lot of information. So we certainly want to try to present our data in different ways. So again, this just kind of gives us a sense, how are we doing by surface each week? So we're doing observations each week. How did we do each week? And then this was, say, monthly, so we want to look at over a greater period of time. And this one I was looking at correlating back to a specific housekeeper and then our totals. So we can see we kind of had that improvement going on, and then we started to drop off. So a scenario here, for example, so let's say we had our celebration of we've made improvements, we sustained it for a couple of months, we had a big celebration. So month 9, then everyone thinks we've taken our eye off the ball. And so month 10, we kind of maybe dipped a little bit. So again, gives us an opportunity to kind of look at what's going on with those trends. All right, so in short, we want to look at trying to get away from those sprays and using of soaking of our cloths in the disinfectant products to apply them. When we have products that may not be compatible with the microfibers, then we'll need to look at different ways for applying them. So for example, using the disposable wipes when we need bleach, the use of the microfiber mop pads, and when we're implementing our performance improvement program, we want to try to make sure that we keep our eye on sustainment. So what does that long-term look like? Here I have some of the references and the links to additional resources. And we have a few minutes for questions. I see the chat. Okay, thank you, Elena. And then I don't see anything in the Q&A. Okay, back to you.
Yeah, so if you do have any questions for AC, please go ahead and put those in the chat box. Thank you so much, AC. That was a fantastic presentation, and definitely one of the topics that we've seen come up multiple times through our program is just, you know, helping to go through environmental cleaning. So we really appreciate the overview and the information you shared with us. There's 2 questions. I'll answer the first one really quick. If you were not able to join us for the whole webinar, it was recorded, and everyone who registered will get a email with the link to the recorded webinar, so you can watch back at your own leisure. The next question we got was, what is the best place to store toilet cleaning brushes on EBS carts?
So typically on the bottom. So we want the toilet brushes, we want them on the bottom of the cart. We don't want them mixed with the other supplies.
We have one more question. I have a question about the cotton mop head. You mentioned double dipping. Is that appropriate for cotton?
So ideally, we would not be double dipping. So the CDC guidelines does speak to we should not be double dipping. However, nonetheless, with the cotton mop heads, that's the process for using them. So double dipping does indeed happen with the cotton mop heads. So I guess in terms of presenting the information, that's what helps us start thinking about maybe we do want to make that transition to the microfiber pads so that we can avoid that double dipping. But yes, it is understood that the double dipping does happen with the cotton mop heads. We do want to make sure that we are changing that disinfectant often in the mop buckets. So there's some information in the guidelines that say we definitely should not exceed more than 60 minutes before we're changing the disinfectant solution in the buckets. And then certainly once the solution becomes visibly cloudy and dirty, then of course we need to make sure that we are changing.
All right, so I'm going to give people another minute for any other questions. And while I give people, is there an issue from a regulatory standpoint with dedicated toilet brushes stored in patient rooms? We've gotten some feedback that is a patient safety issue and strongly discouraged practice.
I don't know that I've ever had a conversation about this from a regulatory perspective. I'm thinking, I don't know that I've ever experienced toilet brushes being kept in a resident room. So from my perspective, my answer would be no, we do not want to keep toilet brushes in resident rooms. If there's other questions as it relates to the regulatory side, maybe Elena, that's something that you could check in with your team to see if they have additional information on that.
Yes, I can. And so going to give people just a minute or two, and in that minute, I'm going to just make a plug for our next webinar, which you're also going to be hosting, Legionella Prevention and Water System Management in Nursing Homes. It has been approved for Alabama Nursing Home Administrator CE, and we are anticipating it being approved for nursing nurses in the state of Alabama. And then you are also going to be doing another webinar for us on May the 2nd, and the registration should be available soon, but that is around enhanced barriers, precautions, and MDROs. So I do not see any more questions in the Q&A or in the chat box. So I just want to, again, thank you so much, AC, for your time. We're looking forward to having you back for our next 2 webinars. I think that really speaks to the expertise that you provide. But really thank you again, and thank you for this wonderful information, and hopefully we'll see everyone on one of our next webinars. So thank you guys so much for being here.
Thank you for having me.